Alrighty guys, so we're gonna go ahead and start with the troubleshooting portion of this class. So this is just the video version. So if you guys end up having questions about some of the troubleshooting, please don't hesitate to reach out to me. And I can always find a time to come and walk you through certain things if they're a little bit confusing here. So we're going to start small and get bigger as far as the amount of troubleshooting that you need to do to get certain things fixed, okay? So right now it's zeroing auto-zeroing. Once it starts back up, we'll go ahead and get started on some of the scenarios, okay? So the first scenario we're going to work with is going to be if our pressure disconnects. So as you can see, we're flatlined from a pressure standpoint. So this is all going to start to say 0 for you, okay? And then it's going to say augmentation below limit, right? So as you can see though, the catheter is still inflating. So you're still at least getting perfusion to those coronaries, and that is because you are on the trigger of EKG. Now, if you're on the trigger of pressure, this would stop completely. It would not be filling in or inflating and deflating appropriately. So the main thing that you need to do when this happens is figure out why it went flat. Did the cords become disconnected? Is your patient completely bending their wrist or something and the art line's cut off? Is any type of power failure happening? You just need to look at all of your lines and make sure everything's connected, okay? I think that's pretty self-explanatory as far as how to reconnect the pressure lines. Sometimes the pressure line will become disconnected from the balloon pump itself. That can happen too, just when you are transporting a patient or moving a patient to a different room. So just making sure that all of your lines are back up and running. That's a fairly easy fix. Like I said, it's mostly a machine issue in the sense that the lines are just not connected where they need to be. Either that or your patient ripped out a line or two, and in that case, might need a little bit of extra hands to help you. Alrighty, next we are going to go ahead and go to a noisy EKG. So as you can see up here, it's a very noisy rhythm. So we don't have good R waves so that the balloon pump can fire appropriately. We just kind of have almost like in a way, the machine thinks it's almost like a V-tachy rhythm. So if you can see, the catheter is behaving pretty erratically, like so. Your pressure lines look all wonky, and now what happened was, so as you can see, you weren't getting a good reading with the EKG, so the deflation and inflation was all wacky, but now it's working awesome, right? It's doing it appropriately. We have a great chair waveform. And the reason that is because your balloon pump, the EKG was all messy and noisy. It automatically diverted to going off a trigger from pressure, from the blood pressure. So now that it's triggering on pressure, it's working great. So the balloon pump will do that, where it will, this is the only time that, like I said when we were talking previously about the trigger source, this is the only time that it will do it automatically, is when you have, for whatever reason, your EKG cannot be read. Let's flip out of that. And now we have a nice rhythm. We fixed our leads, we got our patient settled. Maybe he was getting too excited and started to wake up, one of the two. That can happen, actually happens quite often. So just knowing that if you do have a noisy EKG, figuring out how to place your lead so that that doesn't happen is obviously your first step, but also know that the balloon pump's gonna auto switch the trigger source to a pressure source instead. So I'm gonna have to place this back on standby just for a second so we can switch back to EKG mode. So now we're back on EKG mode. Just gonna give it a second to start back up here. So now we're back and we're ready to go. We have a nice waveform, everything looks perfect, right? So now we're gonna go to EKG lead fault. So if your leads just aren't reading appropriately. Well, it toggled to pressure right away. And now notice how it says over here, lead fault. It will tell you this on your screen, so it's important to pay attention to this when you're doing your hourly checks. It tells you lead fault, so you know a lead's off. And it automatically toggled over to pressure. Okay. Gonna take that off. And now we're back. So it's just important to know that any EKG problem you have, the balloon pump is gonna switch over to that pressure source as the trigger. So now we're back up and going. All right, now we're gonna go to do a couple different things. So we're gonna change, since we're working on EKG stuff, we're gonna change our rhythm. So right now, we are in a normal, nice sinus rhythm. So the balloon pump can sense the R wave perfectly. It's not having any issues. We're just going about, we're happy. Things look great. Now all of a sudden we look up, our monitor's beeping, we're like, what the heck is going on? And we see this rhythm. I know it's gonna be kind of difficult to tell this rhythm on my iPhone camera quality, but this patient is now in AFib. So as you can see, it's behaving kind of erratically, and it's unable to read the R wave. So it'll say auto R wave deflate. So it'll try and read the R wave, but it's having a difficult time. Therefore, our timing for the inflation and deflation of the balloon pump is off a bit, okay? So notice how here, I'm gonna freeze. Notice how here we have not really a longer plateau, not a really good chair form like we do in this beat. So that's a really good indication as well. If you can't always tell just by an EKG if they're in AFib, it's great to look at your waveform for your balloon catheter itself. So as you can see, we have a nice chair waveform that we like, starting to get shorter, shorter, short, short, nicer, completely gone. So that's a good indication to you that your patient's probably in AFib. Now, as you can see, the catheter is still inflating and deflating when the patient is in AFib. So you're at least getting some perfusion to those coronaries. However, it's behaving pretty erratically, so we're not getting the optimum perfusion that we would normally like from this machine. Now, I always say a little is better than none, and in this case, that is true. This isn't a situation where you necessarily need to freak out and call the physician. I mean, obviously alert them if they're not already aware that the patient's in AFib. As long as their systolic, diastolic mean, augmentation, whatever you're going off of, as long as your pressures are sustaining and your heart rate's okay and you're not going into, you know, AFib with RVR, this machine is still gonna do its job and help the patient perfuse those coronaries. As you can see, it's not at a complete standstill, it's still doing what it can. So a little bit of help is better than none. So in this situation, when they're in AFib, we would just continue to watch the patient, like I said, and the physician might start an amio drip. We definitely want to do something to get them out of that AFib rhythm. That's the only way that we're going to fix this. All right. Now I'm going to switch us to another rhythm view. So as I hope we can all see, this is a paced rhythm, fixed pacer at 80. So this is obviously the pacer spike, showing you where it's going. And then as you can see, we're chugging along just fine. So the main thing to know when you are pacing a patient, you can have them paced and still run this on a normal EKG trigger. You don't need to switch it to pacer. It works just fine. So there's really nothing troubleshooting wise. I just want you guys to see what the rhythm looks like when you're getting paced. So we'll flip us back to sinus. So now I'm going to change our rate a little bit. rate of 60. So notice how it's inflating, still 1 to 1, but inflating at a different speed than if we were at a rate of 130. Okay? So this is basically all I want you to know. Now, when the difference is, though, is when you are in a rate of 130, look at how we are kind of missing our nice chair waveform from our balloon pump. So our balloon pump isn't really being that effective when we're not seeing that. It's really not, it's just kind of, once again, similar to the AFib rhythm, just kind of being very sporadic. We don't want that. Like I said, a little is better than nothing, but we want to immediately try and get this heart rate down so that this balloon pump can work how it's supposed to. It's still working, still helping the patient, but not optimally. It's not what we like to see. So the faster you can get that heart rate down, the better, okay? So I'll flip us back to a rate of 80. So now we're gonna go over the different types of pacers that you're gonna see, or like if we're gonna have a patient on a pacer and we're gonna put a balloon pump in them. I'm gonna show you, this typically happens a lot after heart surgery. If a patient needs to come back paced, then we will see this. So I'm gonna switch us to a pacer view. So this was V-paced, which I kind of already showed you. This will be a V-pacing. As you can see, we're chugging along fine. We have great chair waveform. Our EKG is reading appropriately. Things are good. This is typically one that you'll see a lot too in our open heart patients. They'll come back A-paced. As long as you are getting the appropriate sense and capture from your pacer box itself, this machine should work fine, no problem. So the biggest thing to note is when you are pacing on a balloon pump that most of the troubleshooting you're gonna have to do is going to be on the pacer box itself, okay? So no issues there, looks good. All right, just gonna flip us back to sinus. Now we're just gonna go over some typical arrhythmias that we would see and how those affect the balloon pump and what it's doing, okay? So first, ventricular rhythm that we're going to see is a PVC. So as you can see, that just through a PVC. So if you can, kind of watch what it does, what the balloon pump catheter does when the patient throws a PVC. So we're still getting perfusion, things are still going okay, but it has that kind of one-off where it inflates and deflates pretty sporadically. So once again, not something that's going to immediately damage the patient, but definitely something that we're going to want to get under control. So checking your electrolytes, seeing if you can A-pace over their PVC. There's a lot of different, or PVCs, there's a lot of different things that we can look at as to slowing down those PVCs for the patient so that the balloon pump doesn't have to act as sporadic. Now, the thing to note, like I said, is in this situation, it's not something that we're I'm gonna freeze the display here too to show you something, but it's not something we are, immediately, it's an emergency, a doc needs to get in here. It's just something we're gonna watch, and as they tend to throw more PVCs, this catheter is going to inflate inappropriately, and then that's where we would be then diminishing the amount of perfusion that those coronaries get. So as you can see, we threw this PVC. This waveform doesn't really have a good dichrotic notch, doesn't look great, don't love that. And then here, we just have a little bit of a plateau on our balloon pump waveform. Rather than here, we have a nice chair waveform. Here, we're missing it. Okay, and then it takes a couple to get caught up, and then it'll hit another PVC again, and it'll look just like that. So we're just really not using the machine appropriately for the patient when there are PVCs. Now, like I said, as long as things are still stable for them, we can handle a few PVCs here and there, but try your best to see if you can correct those. Like I said, checking electrolytes is huge. All right. Now we're in a couplet rhythm, so we're gonna throw a couple more PVCs in here. So as you can see, I'll try and show you the catheter too when it's hitting those PVCs. You'll be able to tell. So just hit those PVCs there. Just hit it there. Just hit it there. So as you can see, that catheter once again isn't really behaving in a nice uniform fashion. It's kind of a little bit erratic. So I also want to point out the waveform here. Once again, we lost our chair waveform. We lost our nice dicrotic notch. So that's another indication that while we are still getting perfusion, because we are, as you can see, it's still inflating and deflating, it's just not giving us the optimum level that we would like to see. So once again, something that we want to correct if we can. If we cannot, then the physician might just be like, well, it is what it is for right now, and we'll just see what we can do to try and either get their PVCs under control, or it'll just be something that, hey, can we try and take this out? Are they stable enough for us to get rid of this at this point? All right. And like I said, it's important that you guys are seeing this catheter, I feel like, because this is giving you a better view of actually what's going on inside the patient when this stuff is happening. Oh, sorry, just disconnected, my bad. All right, so now we're gonna go into a bigemini rhythm. So as you can see, we went into bigemini. So look at how little of a dicrotic notch we barely even have one when we're in bigemini. Okay, so the perfusion is not great versus, you know, having one or two PVCs. Bigemini is kind of one of those where this really isn't doing anything for the patient. I mean, yes, it's inflating and deflating. We're getting a little bit of blood flow back to those coronaries, but not enough that we would like to see, obviously. So that's what's going on inside when we do have that bigemini rhythm. So I'll hold this here again so you can kind of see when we're hitting bigemini. Bigemini, 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 normal. Okay, so unfreeze the display here and let you guys see a couple more beats with that and what that does to your waveforms. So troubleshooting here, once again, is trying to get these PVCs under control, but people who are in bigemini, it's just very difficult to do that. So it's just one of those things where, you know, continue to let that little bit of perfusion that is getting through go through, and then physicians and other healthcare members can discuss what they'd like to do going forward. So this next rhythm, now we're back in normal sinus. And now we're in VTAC. Okay, so when we're in VTAC, it's gonna be important that we get them out of VTAC as quickly as possible, for lack of a better term. So you can tell here, when we're in VTAC, we have no dicrotic notch. This is just firing and firing and firing, not even purposefully to follow the cardiac cycle. It's just going crazy. Now, if you look here, we have one sinus beat not being perfused, right? So it's important when they're in VTach that we're just getting them out of it as quickly as possible, like we would a normal patient. It's not going to be doing anything for the patient when they're in VTach if we leave them in VTach. So that's really all the troubleshooting you would do. I mean, you're gonna let the machine do its thing, but you're also gonna do your best to get them out of that rhythm. All right, I'm gonna put us back in sinus. So that is really the most troubleshooting that you're probably going to see with the pump. Sorry, I'll unfreeze the frame. This is the most troubleshooting that you're probably going to have to do with pumps. It's really going to reflect in their rhythm. That's where you're probably going to see the most issues. So really the main thing to know is if you're having a rhythm problem, you need to really fix the rhythm. The machine is not going to have anything that you're going to troubleshoot necessarily. You're gonna have to go to the patient and see, hey, how can we get this heart rate lower? How can we get this heart rate higher? How can we stop this VTach? What are we doing with this AFib? Do we still need to be paced? If the pacer's not being sensed appropriately, can we take them off the pacer? So just using your regular critical care nursing skills to get the patient in a spot where this can do optimum work. Now, as I reiterated multiple times during this, you do not need to immediately think if you're having a weird rhythm that this balloon pump isn't working. It is. It's still there. It's still offering that little bit of perfusion, and anything is better than nothing, so that's okay. But it is one of those things where, like I said, if we can get them out of that rhythm, the faster we can do that, the better. So that's all I really have for troubleshooting rhythms and such on the machine. I think that the only other thing that I want to show you for troubleshooting is if this happens. So the balloon pump became disconnected. So you can see, and the trigger alarm says, or the alarm says balloon pump disconnected. So I'm just going to take you over here. This part came out. So let's say we went to turn the patient, we accidentally moved the balloon pump too far, now it's out. So then all you do is slip it back through this hole, push it back in. Okay? Now it's gonna sense that it's back. You just plug it back in and you're good to go. So, but note that for that entire time, you did not have any perfusion to those coronaries, okay? Because the balloon was not inflating or deflating at all. All right, I think that is pretty much it. So as you can see, it's the only other thing that we're gonna talk about, which I want you guys to pay attention to in your post work, is early and late timing of the balloon pump. I'll have a couple tracings of the screen for early and late timing, just so you can see. I don't have anything available on my trainer to simulate early and late timing, unfortunately. But just keep a close eye on that in your post work and make sure that you've gone over that a couple times so that you really understand what that waveform is going to look like when the timing is too early or when the timing is too late, okay? I think that's really it for troubleshooting the pump for right now. Like I said, if you guys have any questions, please feel free to reach out to me. I'm here for you guys. I'm here to help you. If you have anything come up when you're caring for the balloon pump or a patient on a balloon pump and you need me, I am going to be here for you. I will check in on you, answer any questions you have. I know it's kind of weird to learn this virtually, but I think that this is probably the best way to do it for right now. If you guys end up feeling like you want a little more hands-on, please, like I said, reach out. I will get some time to work with you, and good luck. You guys will do great. Thanks.